Welcome to the North Simcoe Muskoka Specialized Geriatric Services Lunch and Learn series on confinement syndrome. My name is Allison Jayawira, and I'm one of the psychogeriatric resource consultants working out of Specialized Geriatric Services. I would like to just, for those of you who are joining us, just remind you of a little bit of Zoom etiquette to make sure that your microphone, which you can find on the bottom left of your screen, is muted during the talk. I also want to let you know that today will be recorded. So if you maybe don't wish to have your video on, feel free to shut your video off, although I do know that today's presenter does enjoy seeing faces. So please, you're welcome to keep your video on. I want to also highlight for you that there is a chat box where you can ask questions, comments, anything like that can go in the chat box. Also, if there's an opportunity to unmute your microphone, please feel free to do that, as I know that is always welcome. We are North Simcoe Muskoka Specialized Geriatric Services has been shining a light on confinement syndrome with a communique that was put out in August of 2020. And with our focus on confinement syndrome heading into the next wave of COVID-19. We are very pleased to provide 5 separate sessions at noon each day this week, which is also Mental Health Week. So we're very pleased to kind of line it up with that. Felt that it was a very important focus to be on confinement syndrome. It gives me great pleasure to introduce our first speaker of confinement syndrome on the Confinement Syndrome Week, which is our Director of North Simcoe Muskoka Specialized Geriatric Services, Sandra Easson-Bruno, who's going to be giving us a good overview of confinement syndrome. So welcome, everyone.
Good morning, everybody. I am going to, if it's okay, if I can share my screen. Allison and...
Yeah, you should be able to now.
Okay, there we go. All right, everybody can see that okay? Are we good, Allison?
We're great.
Awesome, thanks so much. So good afternoon, everybody. As Allison said, just afternoon, beautiful sunny fall day here in Barrie. We are, as Allison indicated, trying to raise some awareness around confinement syndrome as we're headed into week 2. And so we have a variety of different topics this week, but we thought it would be great to start with a bit of an overview of confinement syndrome. So I'm going to talk a little bit about our multidimensional strategy here in North Simcoe Muskoka. I'll get a little bit into confinement syndrome, some of the contributing factors, potential signs and symptoms, and what we can do going forward. And our goal is to have about a 20-minute presentation with a few minutes at the end for questions, and I'll do my best to answer those. And I know Allison's going to keep an eye on the chat box for me. So this is a really busy slide. What I want you to take away from this is that early in COVID, what we did was we took a bit of a different approach. What we realized was that when it came to older adults and their caregivers, the focus and the conversation was very much on the disease itself. So from a staffing perspective, when we think about our hospitals and our congregate care settings like long-term care homes, retirement homes, the IPAC and all the personal protective equipment, all of those sorts of things. And what we realized is there was probably several different dimensions that were being impacted at the same time that we really needed to keep an eye on. So we came up with a bit of a strategy to make sure that not only were we focusing on some of the immediate dimensions or that immediate need, but we also had the other pieces in mind going forward. And that has really been the foundation of our work since March, is trying to pick away at the various pieces to make sure that we were supporting older adults and their caregivers in the most appropriate way possible. So the dimension 1 was really around the disease itself, and these very much tied into, if anybody saw the wave diagram or that came out early in the pandemic with the 4 waves, it sort of aligns with that. So trying to come up with strategies that dealt with the issues around the disease itself. The dimension 2 was really recognizing that there were many older adults who were having urgent non-COVID issues, and we're not necessarily seeking help for those. And we did a little bit of work trying to promote that. Making sure people know the emergency departments were still open, family practice, primary care was still open, just so that we weren't seeing seniors deteriorate out in the community. The third dimension was really, and it's sort of the biggest one, tied to the impact of the COVID restrictions. And so as a result of a variety of restrictions, we have seen our older adults and caregivers deteriorate out in the region. And the fourth dimension was really around broader impact. So when we think of our health human resources, we think of policy change that's needed. We're seeing a lot of conversation happening about that right now in terms of long-term care homes and the need for changes in policy, the need for a national strategy around the care of older adults, pandemic aside, but in general. So the focus of confinement syndrome is really on dimension 3, which is, it's a consequence in so many ways of the impact of the restrictions. So what is confinement syndrome? So if you actually look it up in the literature, you try and Google search it, it's pretty thin, it's pretty bleak. I found this, which is a disorder that in the year 2267 was known as the common psychological side effect of working in space on starships and space stations. That doesn't really apply, but that's sort of what's available out there in the literature. If you actually Google search it, what you will often find is when you put in the term solitary confinement, it's around solitary confinement from a prison-based perspective and the psychological impact. And if you think about it in some ways, I think what we're seeing is not unlike the isolation that is experienced by prisoners when they're put in solitary confinement, in particular on our older adults and their caregivers, with so many of their resources and supports being removed for periods of time. So early on, and where this sort of stemmed from, was there was a case out in France, and they did a bit of a study, and it was a really kind of a random article that I came across on Twitter, and it rang a bell for me. And it talked about why in France there were such differences in mortality rates between long-term care homes, and why some were having more challenges than others. And so they looked at one long-term care home in the southern part of France where there was 24 deaths among 140 residents in a 5-day period. And what they found was that the deaths were not necessarily due to acute respiratory distress. They were due to hypovolemic shock. And when they took a bit of a deeper dive, what they found is, as a result of staffing, as a result of the loss of visitors, many individuals or residents had been left in their homes for periods of time. Staff didn't have the necessary PPE. There was staff that weren't showing up for work because there was such a heightened concern for safety, for their own safety, for the safety of their families. And so in many ways, these residents became isolated and didn't get the care that they normally would give. And if you think about on a regular basis, in particular in a congregate setting like a long-term care home, where the visitors are in providing food, fluids, where the staff are in and out of there, well, now you've got staff that have to don and doff PPE. You've got essential caregivers like family and friends that are not in, and you probably have a lot more people that are requiring feeding over the course of a day. And as a result, the usual pushing of fluids is not likely happening to the same extent that it used to be. So it was a really interesting kind of red flag that made you aware that there was more going on as a result of COVID than just the disease itself. Following that, we saw the military report that came out, which was in early May 2020. And for those of you from the province, you will remember that the military was called into several homes that were really struggling in the early days to support the needs of the residents and the staff as well. And so they took a look and they did a report on 5 different homes across the province that they were involved in. And if you actually look at some of their findings, they were allowed to wander. They were cohorting residents that were positive and negative. There was inappropriate PPE staff. Staff hadn't been trained or oriented properly. If you recall, many staff work in multiple facilities, several facilities, and early in the day, there was decision that you should only be working in one facility for very good reason. So all of a sudden, those usual staff were no longer available and you've got new staff that are maybe not necessarily as familiar with the residents or the requirements of the home. The docs weren't present. You were certainly having staff burnout. Staff were working really long hours. There was issues with documentation. Resident assignment was unclear. There was issues around communication between shifts. There was linen shortages, so residents were sleeping on beds with no linen. Staffing was insufficient to allow resident independence. Things like that would typically do, like going to the bathroom on their own and things like that. So, that would change the way the practice was delivered. There was issues around psychosocial support to try and support the residents that were getting agitated, as opposed to usual behavior support kind of mechanisms you put in place for responsive behaviors. The staff didn't have the manpower or the time, and so we're getting benzos and narcotics. Vital signs were being missed, so you don't really know what was happening with that individual. There was certainly frustration, abusive, at times, inappropriate behavior. Feeding status wasn't necessarily posted. Mouth care wasn't being done. There was issues around staff turning, which would increase the result of pressure ulcers, people calling for help, and the staff just didn't have the manpower to provide what they normally would. The same with palliative care. They weren't charted or they weren't known. Wound care supplies, lack of documentation, multiple falls without adequate assessment. And so speaking to these, this is absolutely not a criticism of the long-term care homes. I think it is the reality that several of the homes in the province, many of the homes in the province were facing as a result of the changes in staffing and all of a sudden having outbreaks to deal with in IPAC requirements that none of them had any history of dealing with at that kind of level and magnitude. And so if you think about the impact on the residents, certainly all of those things are going to contribute to consequences. And we saw some of it, if any of you were following the news or social media, looking at people that were dying of malnutrition inside long-term care homes, dying alone in long-term care homes. The thought of the despair, it's a great article by Louise Aronson out of California, that despair of being alone for those periods of time. And so, if you haven't heard the term before, don't be surprised. It's not really a term that's out there in the literature, as you could see from the literature search. It very much was a term that we kind of came up with and have been using in this region to try and support the conversation that we think needs to happen. And as much as it's probably more obvious in congregate settings like long-term care homes, it really is the isolation that's occurring in the hospitals, in the retirement homes, and in the community. And really, if you think about it, it's only been over the last several months where visiting has been somewhat opened up. There's still restrictions around it. And so for many of these individuals, many homes are still struggling with staffing. This continues to be a risk for many. And it absolutely is happening in the community when you think about the isolation and the changes out in the community services as well. So it's not just about older adults, it's about caregivers as well. So if you think about what could potentially be contributing to all of this, there are social networks and support systems that have been disrupted. So whether you're at home, whether you're in hospital, whether you are in a long-term care home or retirement home, those visitors and support systems that were historically in place were all of a sudden being shut down. Early on, with many of the very tight restrictions that were put in place, we saw things ease up a little bit over the summer. Services were starting to roll again. Support systems were starting to reestablish, but in a very different way. Families were being careful with their older adults, their family members, and trying to keep them safe. And I fear that in the coming months, we will see similar restrictions. We're starting to see it again. We'll ramp up, and our older adults and their caregivers will run into similar issues going forward in the fall. And I think in the fall, we're doubly concerned because now you've got weather that's changing and natural patterns where individuals might be a little bit more in their homes. Access to health and our social programming had been reduced, including less in-person contact assessment and fewer activities or programs. So congregate programs were shut down, activities, things like the YMCA programs, all of those things where a lot of seniors would get out for activity and support were being shut down. Doctors' offices were sort of shut down. You saw in the military report the primary care was often providing virtual support. So all of those usual in-person kind of things that were happening where you have eyes on the individual were changing. As a result of the fear of physical distancing and that elimination of visitors and sort of that lockdown, there was less mobilization, less activity happening. We're still hearing about that. The RECA teams in the congregate settings are doing great jobs trying to come up with really innovative and creative ways to keep people active and moving, but it's tough. Sometimes there's only so much you can do when you can't have a big room of people. And then back to my earlier point, those usual staff, when we saw changes in staffing, those usual staff who actually knew the older adult, whether it was a community provider, whether it was somebody in a long-term care home, retirement home, hospital setting, all of a sudden that's changed. And those norms, the loss of visitors, the lack of people to maybe advocate, certainly changed the eyes and the support available to our older adults and their caregivers. So if you think of potential signs and symptoms, it absolutely is going to vary. It's going to vary based on the level of frailty the individual was starting with and continues to have, their underlying medical conditions, whatever their baseline functional and cognitive status was, their social network structure, and the degree of disruption in their usual activities. So for those that were able to continue to maybe get out and walk, and maybe where the family was coming in and supporting, and maybe had, were good with a computer and get online and do some virtual consults with providers or access services or activities on the computer, may have been better off than somebody who I would say was on clinical frailty scale, maybe a 6, who was beginning to deteriorate already in March and maybe didn't have a big social structure and then became quite isolated. So I'm going to ask those online, and we're going to use the chat box a little bit here, Allison. If you think about what symptoms you have seen or you would expect to see, if you think about that concept of confinement syndrome, what do you think you would be seeing or needing to look out for, have you seen in your experience? When you think about the older adults and their caregivers that have been sort of confined and isolated. And I'll encourage you to start putting some stuff in the chat box.
We're seeing falls, increase in depression for caregiver and client, low mood, depression again, anxiety, decreased food intake, striking out, hitting, irritability, loneliness.
Yeah.
Decline in mobility, deconditioning, memory changes, really good ones coming in.
Yeah, those are awesome ones. So if you think about it from the different aspects of clinical care that you'd be providing, and we think about physical health and mental and emotional health and functional, cognitive, and caregiver health. So if you think about physical health and well-being, just clinically, if you think about it, and you've got individuals who are a bit more isolated and haven't got their usual supports, we run the risk of preventable acute illnesses, some of which may require emerge visits or hospitalization, probably some worsening of chronic conditions. So if you think of individuals that have things like heart disease, diabetes, those things that typically would have been monitored, renal function, renal diseases, those things that might have been typically functioned, that lack of or reduced access, you might see worsening of the conditions or acute exacerbations. Dehydration and malnutrition, going back, if you think about that French study and the lack of, and the staff challenges and the ability to feed people and the loss of those visitors. Pain management might be another one. You might see newer worsening pressure ulcers if individuals are not as active, if they're not being turned as frequently, if they're running into issues with linen and they're being left on mattresses and things like that. Those would potentially be things that could happen. I think the biggest impact that people are seeing is really in that mental and emotional health aspect. When you think about the loneliness, when you think about mental health issues, that anxiety, mood, depression. I know our team was hearing that there were increased requests for MAID, which is medical assistance in dying, in some of the long-term care homes, increased substance abuse, newer worsening cognitive impairment or responsive behaviors. the individual that referenced the hitting out, that certainly would fall under that category of behaviors, right? Where all of a sudden those caregivers aren't in, they're not engaging with them. The individual might be at home with the spouse and those usual supports are not coming in, and now that spouse is, trying desperately to continue to manage and support and feeling tired and maybe not as patient as they were, and the behaviors are escalating. If you think about functional and cognitive status, there's probably a risk for reduction in functional abilities. So their activities of daily living, or even their instrumental activities of daily living, being able to get out and grocery shop and get their medications and things like that. It could be new or worsening bowel or bladder continence, certainly mobility and falls as a result of deconditioning and that reduced activity. And I think my fear is, again, we're going to run into these things as we see restrictions ramp up again in the fall and as we see the weather changing. So they may have been able to get out for a walk in the summer, but as the weather's going to change, that's going to be harder to do. And then certainly when we think about our caregivers, their own health and well-being, so the stress that they're trying to support the individuals at home, as well as potential abuse. Sometimes we know that things escalate to a point where it becomes unmanageable, and whether it's active or whether it's passive, and it's not always just the spouses, it's, individuals are providing care. The children sometimes have these individuals at home, these older adults, and they're trying to provide care. And it may have been fine when everything was shut down and they were home. Well, now the kids are back at school and they're trying to get back to work, and they have an individual who's maybe needing a bit more care. So the challenge for us as individuals and as a society is that two contradictory realities are simultaneous true. Our approach to pandemic containment works, but our approach to the pandemic is causing suffering, eroding physical and mental health, and increasing the deaths of older people. So what can we do? So if we think about different aspects of care, and we think about the clinical realm, or how we provide care clinically to patients, it's certainly being aware of all these potential risks and how we're assessing them. So how are we building these into our assessment tools? How are we keeping an eye on these things? If I think of, community setting, is there 1 week where you have a really big focus in making sure that the individuals are eating well? We know we lost some of our Meals on Wheels programs for a period of time. Are they eating well? Are they drinking? In the long-term care homes, is it, enhanced monitoring of pressure ulcers and things like that, right? Do you take a week at a time and you do a bit of a concerted effort with staff? We know things are going to get worse in the coming months. There is a great competency framework that allows for a comprehensive geriatric assessment, which is what many specialized geriatric services use, which kind of pulls the big picture together, right? It thinks about all those geriatric type syndromes. So there's a great competency framework that was developed by the Regional Geriatric Programs of Ontario. Is there a recreation plan in place for this individual, and is it being followed? One of the things that we're looking at doing right now is, for those in congregative settings in hospitals, there's often activities that are going on, but for those in the community, there's not. And so we're trying to look to see, for our program, can we bring somebody in to help provide some recreation assessment and support to older adults and caregivers that are living at home? Are we using standardized tools and languages so that we're all talking the same language? So as individuals are transitioning between programs, we're giving a good account of what's happening, even never mind organizations, but transitioning between shifts. Have we actually got a care plan that's updated and is being used? Oftentimes we develop all these great care plans and not everybody uses them to the best of their abilities. And when we think about new staff that are coming in, it's really important those care plans are updated so they have something to follow. If somebody has responsive behaviors, is there identification of the triggers and strategies put in place around how to reduce that? Is somebody monitoring their mood over time? How are we doing those sorts of things? And then for things like congregate settings, is there a sign you could put on the door? And we could all argue right now confidentiality, but I think the reality is we have to respect it, but we've got to find that fine balance. So can you put a sheet on the door and monitor somebody's intake? Because I would think if caregivers are the providers are trying to feed people, it's one thing when you have to feed 3 people, it's another thing when you have to feed 7 people potentially at the lunch hour. And so are they all getting full meals, or are the staff going, okay, we did well, we got about half into this person, we got to move on to the next person? Well, that's great. But if every shift only gets half the meal into the individual or half the fluid intake, it will drop. So is there something you can put on doors? How is shift change communication happening? How are you leveraging risk rounds when you think about things like falls and pressure ulcers? Is there other aspects that you might want to consider in those conversations? If we think about education and coaching, what are we doing with our providers? How are we teaching them? How are we raising awareness with them around these various issues? But if we also think about the older adults and their caregivers, what kind of tools are we giving them to help support their self-management? We can't do it all. There's not enough resources in the system right now. So what tools are we giving them so that they can manage things on their own? Maybe they could track their fluids and their food and their activity. And there's some great resources out there. I know on Wednesday, I think it is, Charlene and Melissa, our physiotherapists, are going to be talking about functional decline, and there's some great resources out there like the SLOT tool that, you know, people can kind of track how much activity they're getting. There's stuff that individuals can do on their own, and we have to encourage that right now. When we think about leadership, so for those of you that are leaders within your organization, is there somebody within your organization that's designated as accountable for providing oversight for the clinical outcomes in particular now, right? Is somebody watching for the impact of confinement syndrome? Are there 2 or 3 key indicators that are getting checked on a regular basis for the organization right now? Is there a family presence policy? I know there's a lot of work that's been happening around bringing essential caregivers back in, and there is a way to do it. There is a way to do it and find the right balance. It's really hard because we're trying so hard to keep everybody safe, but in the same token, in the absence of this family or loved ones, we see the isolation, the anxiety, the behaviors, the loneliness. And so how do you bring them in and train them up? I think down at Sick Kids, they were basically training the parents like staff, and you know, they learn the PPE and they learn how to don and doff properly so they can come in and they can still come in and be safe and be with that individual. We need to advocate for change in clinical practice and policy. And we also need to leverage community supports and committee structures. So what are you connected to? What are your tentacles that are out in the system, your networks, and how are we raising awareness and trying to stay on top of this? And then if we think about the realm of research, we could probably look at some really interesting data from RIDE dating way back to March at the baseline and check certain indicators over time. If I was a researcher, I'd love to take that project on and see if we can actually see what's happened compared to a similar period of time and whether we would have seen the same changes. So we put a bit of a challenge out to some of our partners in the region, and this was our way to try and tackle this and raise awareness. We reached out to many of our partners and said, hey, we're going to be doing something like this. Are any of you interested in buying in? And so we had quite a few actually step up, whether it was primary care or hospitals that we sent material out to that they're going to use internally, hopefully to raise awareness with their own staff. And we also then, as Allison had indicated, developed a week of speakers just to try and flag people and make them aware of potential impact. So today was really about the overview of confinement syndrome, but tomorrow we have Dr. Jeff Daniel talking about mood changes. So when you think about that loneliness piece, that anxiety, the depression piece, he's going to talk a little bit about mood changes. Physios are going to talk on Wednesday about functional decline and the impact of that from a COVID perspective. Our psychogeriatric resource consultants, in particular Deb Lashbrook, are going to talk about delirium on Thursday. And then on Friday, Dr. Kevin Young, our geriatrician and physician lead, is going to talk about nutrition and hydration in older adults. So for us, it's really about raising awareness. We're not hearing a lot of this conversation necessarily happening from a system perspective around the concept and all of these restrictions sequelae. And so we're hoping that some of you on the line will take that and use some of this information within your teams. I know our specialized geriatric services teams, we sent out a bunch of information, and they're going to try and do little things. And we said, even if you yourself learn one new thing out of the material that's available, or if you're able to convey it to one person, then we've made some difference, and that's all we can hope for right now with our older adults.
Thank you so much, Sandra, for this wonderful presentation and this introduction to confinement syndrome. It gives us all lots to think about, and we know that we're all supporting older adults with complex needs. And as we move through this pandemic, we're learning more about its complexities and its effect on all of us. So thank you so much for highlighting confinement syndrome.